So our final speaker will be talking about something usually a little bit more positive in terms of birth, and specifically home birth as an alternative to hospital birth in Lebanon, I believe, with Syrian refugees. So this is Mathilda Jabbour, who also works with Richard Giordano at the University of Southampton. So Mathilda is a master's student in leadership and management in the Faculty of Health Sciences at the University of Southampton, where she is a Said Foundation scholar. She has a background in nutrition, in business administration, and healthcare management, and is using that to assist with the healthcare crisis of Syrian refugees. Our current research, as I mentioned, is on the safety of home birth. So, thank you.
Hello. So my topic is about home childbirth for Syrian refugees in Lebanon. We will start by establishing the purpose, so I will give you a context around what's happening and why the question was raised. And then I will tell you the research question, the method I took to answer the questions, the result I obtained, and the implications for practice, and finally a small conclusion. So let us start with a little bit of background information. In March 2011, the war started in Syria, and with it, one of the worst refugee crises of recent history started. People fled from Syria to neighboring countries such as Lebanon, Jordan, and Turkey in the pursuit of safety, of course. More than 1.5 million refugees were hosted in Lebanon. Lebanon is a very small country of only 4 million people. So in less than a decade, Lebanon experienced a 25% increase in its population base. This means 25% increase in need for home, shelter, healthcare, education, etc. My focus is on healthcare and tertiary care, maternity tertiary care. Although the healthcare system in Lebanon was resilient and was able to provide the services, the government was already in debt even before the war in Syria. So they couldn't finance the refugees, the cost of care for refugees. The UNHCR is currently financing 75% of the cost for maternity and emergency tertiary care for Syrian refugees in Lebanon. But keep in mind that the refugees are very financially deprived. So they are often found unable to pay their 25% co-payment. This resulted in two problems. They would either resort to unassisted home childbirth, so a woman would deliver on her own, or they would do other risky behaviors such as crossing borders to access free healthcare in Syria, or they would simply access the service and not settle their payment. This will result with two problems, either on the Syrian refugee side, which is more important, of course. It increases maternal and neonatal risk, while on the Lebanese healthcare system side, it's also not good because it's a private sector and it cannot hold the incubus of the 25% bill that is not settled. This is why I thought that we need to add to the current model a cost-efficient alternative to in-hospital care. So I had a research question, which is home childbirth a safe alternative to in-hospital deliveries for low-risk women that can be used to decrease the demand of Syrian refugees for tertiary care in Lebanon? So the question has two folds. The first one is whether it is safe or not, and the second part, whether it is applicable in the Lebanese setting or not. First, regarding the safety, I did a review of literature to determine the safety of home childbirth. Keywords were derived from the research question and searched in CINAHL, Cochrane, Embase, Medline, followed by a small hand search. The timeline for my research was only the past decade, because midwifery practices can change significantly, causing bias in more than a decade. So I thought that 1 decade would be enough. This resulted in 11 articles after screening and critical appraisal of literature using CASP. All the articles were cohort studies. Although the gold standard for determining the safety of a practice is case control studies, but in the case of home childbirth, it is impossible to do a case control study because women do not accept to be randomly allocated to a place of birth. So in light of this event, Cochrane called for a review of literature on cohort studies, which is what I'm doing. The results were under 3 themes: maternal interventions, maternal morbidity and mortality, and neonatal morbidity and mortality. For maternal interventions, they were mainly about outcomes such as rates of spontaneous birth, cesarean sections, forceps or vacuum delivery, labor augmentation, episiotomy, need for pain relief, labor augmentation. For maternal morbidity and mortality, postpartum hemorrhage, perineal trauma, maternal death. As for the neonatal side, it's their rates of admission to neonatal intensive units. If the UPCAR score is less than 7 in the first 5 minutes, the birth weight if it is less than 2,500 grams, and perinatal and neonatal death. Results obtained showed that home childbirth is associated with a decrease in the rate of maternal intervention for both nulliparous and multiparous women. So it decreased the rates of maternal intervention, while for the safety for the mother, it increased the risk for maternal morbidity and mortality for nulliparous women, while the risk didn't change for multiparous women. The outcomes for the baby was similar. For multiparous women, the rate was the same, while for nulliparous women, the rate was increased. So a conclusion can be made that home childbirth is a safe alternative for in-hospital birth only for multiparous low-risk women. So the first answer about whether it's safe or not, it was established that it is safe. But whether it's applicable or not to the Lebanese setting, I had to study the countries where the cohort studies were done. In these countries, there were clear guidelines to identify low-risk women. So we need clear guidelines in Lebanon to identify low-risk women. The home childbirth was integrated in the system and was done in a place at an acceptable proximity to a hospital. So let's say a team of midwives want to practice home childbirth in a setting. They should make sure that they have contracted with a hospital that is at an acceptable proximity in case they needed emergency care. This makes Lebanon the perfect setting for applying this practice. Lebanon is a very small country with numerous hospitals all over the country. So wherever you are on the map, even in the space where you have in the red area, you can access a hospital in less than half an hour because the whole country is 10,452 kilometers square. And to add to the applicability of this service, the UNHCR have already contracted with hospitals all over the country. So all the hospitals in blue are already contracted with the UNHCR. So we can introduce this service easily by partnering with the government or the UNHCR. So in conclusion, home childbirth is a safe and cost-effective alternative for in-hospital birth, applicable in the Lebanese setting for low-risk multiparous women. By providing this alternative, on one hand, the most important part, women will not resort to risky behavior such as unassisted childbirth. And on the other hand, private hospitals will not bear the incubus of unsettled co-payment.